All right, I'm Eva Koeller. I'm a general surgery resident at Brown, and I'm going to be presenting a study that our group did that showed this. Great. So we have no relevant disclosures. Smoking remains a really significant problem in the U.S. CDC data showed that in 2021, 11% of U.S. adults, over 28 million people, were actively smoking. Smoking has been shown in multiple studies to increase your risk of wound complications in the postoperative period across surgical subspecialties and in hernia repair specifically. A study that was done in 2019 looked at 418 smokers and 418 people who had never smoked, all of whom underwent elective open ventral hernia repairs. And they found that patients that were smoking at the time of their operation had a significantly higher risk of surgical site occurrences and seromas after surgery. As a result of this study and other studies, some surgeons won't even offer elective open ventral hernia repairs to patients that are actively smoking. That being said, minimally invasive hernia repair is becoming increasingly common. According to Medicare beneficiary data between 2007 and 2018, the rate of minimally invasive surgery for umbilical ventral and incisional hernia repairs increased from 2% to 22%, as you can see on the figure there. So this begs the question, does smoking also increase the risk of complications in minimally invasive ventral hernia repairs? So our study included 102 patients, all of whom underwent robotic eTEP repair of their anterior abdominal wall hernias at the Miriam Hospital Brown University between November 2019 and October 2022. All of the repairs were reinforced with a large microporous polypropylene mesh, which was placed in the Retro-Rectus space. All of the operations were done using either the XI or SI robot, and 34.3% of our patients also required either a unilateral or bilateral TAR to facilitate closure of their hernia defect. So we sorted patients into a couple of different categories based on their smoking status, which was determined by chart review. We collected data for all patients on demographics, operative details, as well as outcomes, which were compared using ANOVA and chi-square tests with a p-value indicating significance of 0.05. We categorized patients into a couple of different categories of smoking status and did a few different comparisons to try and get a more nuanced view of how smoking really affected their postoperative outcomes. The first thing we looked at was comparing current smokers, which made up 18% of our study population, to former smokers, which made up 37%, and never smokers, which made up 45%. We also compared current smokers to patients who were not currently smoking, which included both former smokers and patients who had never smoked. And then finally, we compared never smokers to patients who had ever smoked, so both current and former smokers. We found in terms of demographics that there was a significantly higher rate of reported alcohol use in patients that had ever smoked compared to never smoking, and COPD rates were also significantly different between current, former, and never smokers, which is not surprising. In terms of operative characteristics, there were no significant differences between smoking groups in any of the outcomes we looked at, including operative time, estimated blood loss, total hernia defect size, whether or not they required a TAR, number of defects, or hospital length of stay. And then when we looked at outcomes, we found that the most common recorded complication was a seroma, which we found in 8.82% of our patients. But is a seroma really a complication? Seromas are often self-limited. They usually don't require any intervention and resolve on their own. Some have argued that, especially after hernia repair, seroma is actually an inevitable result of the operation and the subsequent healing that takes place. In 2019, a classification system was actually proposed to categorize seromas after laparoscopic ventral hernia repair. They suggested grouping them so that any seroma lasting less than a month was categorized as a type 1. Seromas that lasted longer than that were type 2. Any symptomatic seroma was a type 3, and seromas that required treatment were type 4. So in an attempt to only include clinically significant complications in our study, we excluded any seroma that was just noted on physical exam, that was asymptomatic, that didn't require any sort of intervention. We did include type 3 and type 4 seromas. And so with that, we found that there were significantly different rates of these clinically significant seromas between current, former, and never smokers, and that current smokers had a significantly higher rate of seroma formation compared to patients that were not smoking at the time of their operation, 16.67% versus 3.57%. We found similar outcomes for surgical site occurrences, which was a combined complication looking at hematoma, these significant seromas, skin necrosis, and wound dehiscence. So, in conclusion, for our population, which again is patients undergoing elective robotic eTEP repair of anterior abdominal wall hernias, we found that current smokers had a higher risk of these clinically significant seromas compared to patients that were not smoking at the time of their operation. That being said, there was no difference in this outcome for patients who had ever smoked compared to those that had never smoked, suggesting that the risk normalizes after smoking cessation. And then finally, there was no difference in other kind of more severe complications such as infection, risk of reoperation, readmission, return to OR. So what does this all mean? I think the most important question is this clinically significant? And I think the answer to that is yes. So we specifically excluded seromas that were asymptomatic and just seen on exam. And so what we found is that active smokers have a higher risk of seromas that are going to cause them pain, cause them to come back to the office, need a procedure, need imaging, or something like that. That being said, like I mentioned, there's no difference in infectious complications, recurrence, return to the OR. The limitations of our study include that it's a smaller sample size and thus a smaller number of absolute complications, as well as its observational and retrospective design. In terms of next steps, I think a prospective study to determine the optimal timing of smoking cessation before surgery is needed, as well as studies to identify operative techniques that may reduce seroma formation. Ultimately, what I want you to take away from this presentation is that when you're talking to smokers about hernia repair, even if you use a minimally invasive approach, there is a higher risk of clinically significant seroma formation. And so that conversation should be used as an opportunity to encourage smoking cessation. That being said, as there is no increased risk of recurrence or infection, readmission, hospitalization, I don't think that active smoking should be seen as an absolute contraindication to minimally invasive ventral hernia repair. These are my references, and I can take any questions.